Welcome to the Ocular Surface Academy podcast, TFOSdewsii edition. Join us as we meet with the researchers behind this landmark international consensus. Each episode will feature practical clinical takeaways. Before we get to today's episode, here's a quick word from our sponsor.
The Systane iLux system is a device designed to treat patients with meibomian gland dysfunction, or MGD. It is the leading cause of dry eye. Dry eye is caused by deficiencies in the quantity and quality of meibum or other tear components within the tear film. Around 30 million people are estimated in the United States to suffer from dry eye symptoms. According to a study, 86% of dry eye sufferers are reported to have clinical signs of meibomian gland dysfunction. Healthy meibomian glands produce clear and liquid meibum. Dysfunctional glands produce meibum that is either cloudy or thick and paste-like. In some cases, the glands do not express any meibum when compressed. This may indicate fully blocked, capped, or damaged glands. The Systane iLux system allows eye care professionals to target dysfunctional glands and improve signs and symptoms of MGD using localized heat followed by compression therapy. To clear the glands, the eye care professional positions the Systane iLux device on the eyelid and applies light-based heat to melt the meibum. Compression of the lids after heat therapy allows the eye care professional to express the unhealthy meibum. When the blockage is cleared from the unhealthy glands and/or clear, healthy meibum is seen on the lid margin. The procedure is complete.
Welcome your host and co-host for today's episode of the Ocular Surface Academy podcast, Dr. Scott Schachter and Dr. Christopher Starr.
Welcome, everybody, to another edition of Ocular Surface Academy, digging into TFOSdewsii. I'm Dr. Scott Schachter, joined by my co-host, Dr. Chris Starr. We also have Dr. Dan Nelson and Dr. Jennifer Craig today. Dan and Jennifer, welcome, and thank you so much for joining us in this review of the executive summary of TFOSdewsii.
Thank you.
Now, Dan, I have to admit, sadly, for some reason, I'm not familiar with your name, and I know you did a lot of work on this, and as an ambassador for TFOS, I'm embarrassed to say so. Can you tell us a little bit about your background and how you ended up here in charge of executive summary?
Well, it's interesting. It goes back to when I finished my fellowship in the early 80s, and we actually had probably the predecessor meeting of TFOS. It was called the Lacrimal Gland and Tear Society, and a group of us met, and there happened to be about 25 of us that were interested, and most were interested in the lacrimal gland. There were only a few clinicians there. And then over the years, that developed into holding larger and larger symposiums at ARVO, and then eventually the large TFOS meetings around the world. I started out at the University of Minnesota, actually taking over for one of the founders of ARVO, John Harris, who was a corneal external disease person. And I was sort of delegated to take care of all of his patients, which were just lots and lots of unusual dry eye patients. So I developed an expertise in that area such that I described myself as an external disease cornea person rather than a corneal external disease person. I was involved in the first NIH industry workshop headed by Mike Lemp back in the mid-90s, and then was involved in both DEWs, the meibomian gland, the contact lens, and then I was invited to chair, along with Jenny as my co-chair, Dry Eye Workshop 2.
Very good. What was your education? Where was your education?
So I did my undergrad at the University of Minnesota in Duluth, my graduate medical work at the University of Minnesota, and I did my corneal external disease fellowship there at the University of Minnesota under Drs. Lindstrom and Doofman.
Oh, excellent. Everyone knows good old Dr. Lindstrom, real expert in cornea. And Dr. Craig, give us a quick overview of your extensive career.
Okay, so I'm an optometrist by training. I trained in Glasgow in Scotland, and I did my Ph.D. there under the supervision of Professor Alan Tomlinson. And I moved to New Zealand, and I'm now a professor in the Department of Ophthalmology there. And yeah, I had the pleasure of being involved in TFOS right from the start. I wasn't involved in the original dry eye workshop, but with Dan, we were part of the definition and classification subcommittee for the meibomian gland dysfunction workshop. And that was when I met Dan, and we worked really well together. And I'm pleased to say that he then chose me to be the vice chair of TFOSdewsii to work with him as the vice chair of the second workshop.
Excellent, excellent. I know you've published plenty. So we're not going to go through each subcommittee here, but we may talk a little bit about definition and classification, because I think that sort of set the tone for a lot of what followed. Dr. Nelson, tell us a little bit about that subcommittee.
Well, it was interesting because one of the first challenges was, here you have a committee that's meeting to define the definition, and we haven't really received all of the subcommittee reports. So do we define the definition and let them design the reports around what definition we had, or do we wait and hear those reports and then develop the definition? It got to a point where, in order to solve that issue, I had to bring everybody to St. Paul, Minnesota in the dead of winter to discuss a revision of the definition based upon all of the reports that had come in. And actually the second biggest issue was, I can remember distinctly at our first definition meeting, we had people from all over the world, and we asked them, what's the word you use for dry eye in your language? And describe what dry eye is. And that was one of the challenges of an international workshop is dry eye really defined the same in the United States as it is in Japan, as it is in African countries? And that led to a very careful definition that the words really had to mean something in every language around the world and be interpreted similarly there too.
What were the biggest changes that occurred?
Individual word was, we spent so long over each individual word. It was quite incredible. You wouldn't think you could do that, but it's, took a long time to come up with a definition. And like Dan said, because it's very important for TFOSdewsii that everything was evidence-based. So our definition and redefinition needed to be based on the evidence. But of course, we needed to gather all that evidence or have everybody else, all the subcommittees gather that evidence first. So yeah, it was definitely a moving feast trying to come up with that definition.
Was there sort of a tentative definition that was sort of at the outset of the whole initiative, kind of a moving definition that you guys had that was, or was it just the original TFOSdewsii definition that we started with?
It certainly started.
And then as the evidence came in.
It started with that, but there were issues with that first definition that people were trying to overcome. It was too long. We wanted it to be streamlined. They wanted it to be a single sentence, because the issue with the first one was that people would quote the first sentence and miss off the second sentence, which was actually important, had important information in it. So we vowed to make it a single sentence. We tried to make it short, and I guess that was the point I think we were at, Dan, when we went to Minnesota, was we'd managed to make it really short and snappy, which was awesome, except it then it wasn't specific enough for dry eye, because dry eye is one of many ocular surface diseases. And it was really important for us in the definition to make sure that we created something that was specific to dry eye, that wasn't going to, for somebody with allergy, that was going to describe exactly the same, because it needed to be quite specific to dry eye. So that was, I guess, how we ended up where we were.
You had the same question I did, Chris. Was there, you had mentioned that did you create a new definition and then modified it based on the findings of your subcommittees?
Well, if you look at the first DEWS definition, there wasn't really a good description of pathophysiology in it. The most controversial parts were related to osmolality. And then in the new definition, really until you got to the pathophysiology report, including hyperosmolarity, ocular surface inflammation and damage, neural sensory abnormalities were important. And about the same time as the definition was being developed, work was being done that showed that there was a lot of patients presenting with dry eye symptoms, but no signs. And for years, it's been known that the signs and symptoms don't correlate. Well, there's probably a group of patients that really have a pain syndrome. And we've been treating all those with with calling them dry eye and really not having very effective treatments.
Yeah, which is where the neurosensory part of the definition which was new to this definition, really brings home those points, and probably the most important addition to the definition with the TFOS making people think about the corneal nerves as central to the etiologic process and ruling out nerve-related issues and not calling everything dry eye like we used to do, and which, as you said, led to a lot of frustration for everybody, patients and clinicians, because people weren't getting better. We're treating them maximally. They're not getting better. Everybody's scratching their head, but everybody's also annoyed and frustrated. And now, as we learn more about the corneal nerves, now we have other avenues to go that are not dry eye technically, but related in the ocular surface disease realm.
And that really led to the classification scheme, which is, in a way, it's sort of, well, yeah, you have symptoms, you have signs, you have symptoms. You have signs, you don't have symptoms. You have symptoms and no signs, and then you don't have either. And a fairly simplistic approach, but I think from a practicing standpoint for the clinician, basically looking at it that standpoint, if they don't have signs or symptoms, obviously, that are specific to dry eye, don't call it dry eye.
Exactly.
And the same thing, you had to deal with the issue that where patients would present for various types of refractive surgery or cataract surgery and have no symptoms, but you would have findings that look very much like dry eye, and you needed to have a place to classify them and determine how do you treat them.
And setting the right expectations, I think, Dan, do you not think for the clinician as well as for the patient, if you have somebody without symptoms, but you see frank signs of ocular surface disease and you need to do something about it, you can't persuade the patient to comply because they're going to feel better afterwards because they felt fine before you started. But you need to change your tack in order to persuade them to be, really looking after the ocular surface in order to get the best outcomes following surgery, for example, or following contact lens fitting. So yeah, I think it really helped with setting expectations, understanding which section your patient fits into. And that's important for the clinician, but it's also really important for drug development and device development for dry eye. And so I think it was really important for researchers as well to make sure that we were selecting patients from the right group in order to hope to get good outcomes. A lot of drugs fail if the inclusion criteria are too broad and you take on anybody you think may just possibly have dry eye, then of course they may not respond appropriately. So I think it helped with that as well.
And that definition also fed into not only clinical care, but from epidemiological studies. If you look around the world, everybody defined dry eye different, and you really couldn't compare epidemiological studies. And the same thing with clinical trials. The reason that a lot of clinical trials fail is you're putting patients in that have symptoms and signs, or symptoms and no signs, or have signs and no symptoms, and you're expecting outcomes that you can't obtain because the group is so heterogeneous.
Blepharitis gets a lot of mentions. I know later on in some of the subcommittees in diagnostics and management and therapy. How challenging is that with all the overlap that we have between evaporative dry, aqueous insufficiency, blepharitis, allergic conjunctivitis, etc.? Was it difficult to isolate dry eye disease from the rest of that?
I mean, it's funny when you look at the classification system. There's the aqueous deficiency and evaporative dry eye. I mean, the overlap between those had always been realised. If you read back carefully in the Dew's original dry eye workshop report, you see that they were both recognised and the overlap was recognised, but it wasn't part of the picture. And so this time in the visual, this time in the illustration, it shows much more clearly that overlap. I think that was always recognised. I think, and this feeds into the pathophysiology report, is understanding that dry eye is all part of that vicious circle. There are many different triggers that feed into a vicious circle of dry eye disease, and ultimately patients may have features of both evaporative and aqueous deficient dry eye. But the important thing for the clinician is understanding as best as possible where the source is in order to choose the right treatment. And so yes, blepharitis is incredibly important, most specifically meibomian gland dysfunction, which has a major impact on the lipid layer of the tear film. And without sufficient oil, we know that tear evaporation rates increase in vivo studies. And so it's important to have functioning glands, and this is the problem we have in blepharitis. So yeah, understanding that, but also understanding, as Dan said, the true dry eye, rather than the paradoxical wet dry eye as you get an evaporative dry eye. Understanding in the aqueous deficiency the role of lacrimal gland being functional as well is critical. So yeah, so we see that there's a spectrum within the diagnostic subcommittee. There's the importance of diagnosing a dry eye. And for that, they talked about the global features of dry eye. So those are things like the instability. Those are the things that tend to be mentioned in the definition. It's the instability, the ocular surface damage, the hyperosmolarity. Those changes occur in dry eye, irrespective of whether the patient started with an evaporative problem, with a lid problem or an ocular surfacing problem, or whether it's a true aqueous deficiency problem due to lacrimal gland insufficiency. Yeah, so I think understanding those, making a diagnosis for dry eye is the global signs first of all, but then subclassifying the dry eye into either aqueous deficiency or evaporative as best as possible, or understanding where on the spectrum the patient lies to choose the right treatment is critical.
We don't really have any good studies that really follow someone with no dry eye to dry eye to know how they progress through it. I mean, in a tongue-in-cheek way, you can say, well, does a patient with dry eye have blepharitis? Well, you can say, you know what? They all do. And if you think about it, if you have an aqueous deficiency, you start getting surface changes, you're going to affect the blink rate. The blink rate's going to go up then down. They're going to get plugging of their glands. Or just the opposite, it can occur. They have meibomian gland dysfunction. It leads to inflammation on the surface of the eye. You plug the lacrimal gland. So in the end, depending on when you see them in the chronologic order of their disease, they're likely to be mixed at the end. So in my practice, where I'm seeing people that have seen, 2 or 3 ophthalmologists, by the time they get to me, they have a mixed combination of the disease, whereas early on, it might be just aqueous deficient. But the practicality is there's more blepharitis and meibomian gland dysfunction in the world than there is lacrimal gland disease.
I'll say, actually, one of the words that was so critical in the definition and throughout the DEWS report, TFOS DEWS 2, was this word homeostasis and loss of homeostasis. And basically, what you just said was kind of describing how so many different things can feed into this vicious cycle that all basically lead to a loss of homeostasis. And the overarching goal as clinicians is to restore homeostasis. And it really is fascinating. It was just so beautifully thought out and worded in the TFOS DEWS 2 report. And I think that definition, that's why the definition was so important and so well done. And I'm so glad that you spent the time and had the extra meetings and flew everybody around the world to get that definition, in my view, pretty much perfect, at least for now.
It's good to hear, because homeostasis, that word probably had more discussion than any word in the entire definition.
That's a great word, though, to describe that imbalance. I mean, it's basically just saying the system is in imbalance and we need to do something about setting it right, identifying what's gone wrong to set that right. So, I think that was really important, rather than trying to make it very specific, because that was one of the problems with the first definition, was the second sentence used to get missed off because people thought they were a requirement, that you had to prove that people had these individual things in order to have a dry eye, and that was not the case. I mean, obviously in TFOS DEWS 2, the diagnostic methodology subcommittee spent a long time coming up with a good algorithm for how we should be testing patients, but it's in the terms of the definition, it's understanding that there is that loss of homeostasis, which may be identified through very many different tests that people can use in a patient.
Was it your job to create the subcommittees?
Well, the board of TFOS really decided what would be the different committees. And Jennifer,
we have a steering committee. There's a steering committee set up, and there's a lot of discussion to make sure we cover all the important aspects.
That's why the iatrogenic in the other committees, 2 or 3 others were added in addition to the original dues report because of segmenting them out of the rest of the report, because they would, if you put hormones into the pathophysiology, then the report becomes unwieldy.
Yeah, and they're based on the evidence that was out there. So before TFOS Dues 2 kicked off, obviously the reason for doing that was because there was such a huge amount of new evidence in this area. We'd had 10 years, well, close on 10 years since the previous publication of the TFOS Dues report. And there had been as much research in dry eye published between that time as had ever been published before the original workshop. And so that was the reason for bringing the TFOS Dues 2 to fruition. And so it was on the basis of that. TFOS Dues 2 is evidence-based, it's not opinion-based. So it was very much looking at the scope of the research that had been published there, and then making sure that all those areas were represented, which is why there was the sex, gender, and hormones. It's why there was the iatrogenic. It's why there was the pain and sensation report, particularly the increasing literature in that area as well.
I think I just looked at it here in the eye industry report. There are a little under 2,000 references to dry eye in the literature, and in 2016 there were over 8,000 articles published on dry eye between those 2 reports. So there was a lot of information. And you can see it by if you printed out the Dues 2 report and compared it to the Dues report, it would be substantially greater. One of the challenges that people objected to a bit was having so much information in one spot, because they said no one's ever going to read it.
I was just going to ask you.
We have the executive summary.
That's why we did the summary, right?
It's the 13 pages that you can get away with reading if you just want to get the headlines of it all.
Well, at tearfilm.org, you can actually download the report in several different languages. And, and I recommend to doctors just go through a subcommittee at a time. Some are short, some are 10, 15 pages, some are much longer. A lot of the pages are references, which are a great resource as well. But what I've loved so much about this is that I do a lot of speaking around the country about dry eye disease, and I run a Facebook group called OS Docs, which is ocular surface based, and we get a lot of questions about, well, I've got this patient, I don't know what to do. And I think despite all the public awareness attempts, that doctors still don't quite recognize that there is this consensus that was put together looking at how you looked at the last 10 years of research?
Focusing on the last 10 years, it wasn't ignoring the rest of the research that happened before that time. It was
focusing on that. And you spent about 2 or 3 years putting this together, correct? And so we have this international consensus where we know how to define it, what it means to patients, what the impact on quality of life for patients. We know about the neurosensory component. We know how we should diagnose it, and we know how we should manage the condition. And so this beautiful framework is here for us to consume now. And I do recommend doctors just go through one subcommittee at a time, and it's quite consumable, well written, and certainly, as you said, evidence-based above all. It's not someone's opinion here. This is all based on research, and I'm constantly saying to doctors as well, you didn't just look at the conclusions, right? You looked at everything, the p-values, the n, the commercial interests, the retrospective or prospective study styles. And I'm not sure in the clinical trials section, did you talk about that aspect in terms of qualifying what data what studies you would use?
Yeah, there's obviously different levels of scientific levels of evidence. And the best studies are ones that are double masked, so that the clinician who's collecting data from participants is not aware, for example, if you're trialing a new drug, they're not aware of whether the patient is taking the drug or the vehicle in order to remain unbiased. So you want that to be double masked. You want the participant not to know which one they've been given, because bias is just so easy to introduce into clinical studies. And that takes away the impact of whether or not we can trust in the outcomes. So the clinical trials workshop spent a long time talking about how clinical trials should be set up. how when we do clinical trials, we need to set them up beforehand. We need to have a plan beforehand. Our research ought to be hypothesis driven. So you declare your hypothesis before you start and you set up the study appropriately at that time. And then you report on what you actually said you were going to do. And I mean, that may sound obvious, but a lot of studies don't do that. And they may cherry pick aspects that they didn't even think were going to turn out to be exciting, but turned out to be exciting. So there are a lot of rules, really, I guess, in how we should be doing research and making sure it's as strong as it possibly can be. And I mean, I'm saying, there's exciting findings and we can't report on them. We can report on them. We just need to do that in such a way as to acknowledge that this was something that we found that we didn't expect. Let's use that information that we've gathered here to set up the next hypothesis-driven study in order to investigate that appropriately. So we are seeing, and I mean, I'm aware of this in the literature, we're seeing an increase in the quality of the studies that are being published now, which is great. The more high-quality studies we can have, the more we can trust in the outcomes.
Yeah, I think one of the, if you look at the beginning, the definition and classification. And if you're going to look at, since 2017, the amount of literature that's come out in dry eye is even greater. And so do you have to write another report? Well, the answer is no, not yet, because the definition and classification pretty much the same. The clinical trials is telling you what you've got to do to add new information. And really the skeleton is there to start fitting in and removing pieces. So if you look at the management and, there's new management tools that have come up in the last year. How do they fit in? Well, I think the report gives you the ability to fit those in the specific place where you think they're going to be more benefit based upon what's been shown in the literature from clinical trials that people will have the opportunity to read.
Yeah, and I think the other good thing is the diagnostic methodology subcommittee chose a path that we needed to go. Basically, they were putting a flag in the sand and saying these are the clinical tests that we should use to diagnose a dry eye, to subclassify dry eye into different aspects. And if we all use those same tests, we will be saying the same thing to patients. So that's important for patients, it's important for clinicians, but it's also important for clinical trials in order to be able to prove whether drugs or devices or different strategies for managing dry eye and ocular surface disease are actually making a difference. So yeah, and also even for the epidemiology, going back to that, where if you look at the epidemiology subcommittee, they said dry eye occurs in somewhere between 5 and 50% of people. Well, how useful is that? I mean, that comes from the fact that we've not all been using the same criteria for diagnosing a dry eye. So with TFOSdewsii, if we adopt these published criteria, this consensus criteria, which is based as best we could on the evidence that was available at the time, if we all use that, then we can move the field further forward faster. Use it, because we can compare trials, we can run trials using the same inclusion criteria, which then means you can, and if you use the same outcome measures, you can do meta-analyses. You can put together data from sites all over the world to learn more about, different treatments, about, all the different factors to do with dry eye. Being able to put it all together is very, very helpful, much stronger.
Yeah, and the report sort of identified areas where we assume we know about dry eye in a specific country or population where there's nothing published. But that's changed a little bit, where there's more studies coming out of other Asia, other than China and Japan, and out of Africa and South America. So I think we're seeing it become more of an international basis from the standpoint of research and investigation.
Which is really critical, from the ethnic perspective, but also from the environment as well. Environment is something we know that has a big impact on the ocular surface. So understanding the differences in different parts of the world is really critical. And like Dan says, I think one of the important things that TFOSdewsii came out with, that all the TFOS reports do, is they highlight the information that we know at the moment. They tell us where we've got to at the moment, but most critically, they tell us what we don't know. And I think that's something that's fascinating, as in my role that I've had being parts of the subcommittees, is we sit and discuss things and go, well, of course, because we know that. And then we go, do we know that? Actually, let's look back in the literature, and there are so many assumptions made, things we think we know, and you realize there isn't actually the evidence in the literature to support that. And so tfosdewsii in particular, since that's the one we're talking about, highlights a lot of the gaps that we have in our knowledge, and allows researchers, clinical researchers, scientific researchers, to go out and fill those gaps and help us learn more about it. So that when we come to tfosdewsii, whenever that is, we'll be better informed in order to be able to move forward. But yeah, the critical thing right now is sticking to what we found in tfosdewsii, everybody using that to help us gain more information to allow us to move forward.
How do you think the uptake has been in ophthalmology, Chris? You based a lot of your Ascaris pre-surgical workup on tfosdewsii. Do you think there's a lot of awareness in ophthalmology? There's been certainly a lot more buzz about the impact on vision and refractive and cataract surgery.
Yeah, I think, has every ophthalmologist read tfosdewsii cover to cover? No. That being said, I think a lot more people are aware of it. And I certainly think the iatrogenic report and all of the concerns around surgery, and not just surgery, but anything we do could potentially cause iatrogenic dry eyes, whether it's surgical or drops or virtually anything that insults the ocular surface. So I think that has certainly piqued the interest of a lot of ophthalmologists, especially sort of the traditional high volume surgeons who might have not cared so much about dry eyes or thought it was boring or irrelevant to what they do on a day-to-day basis. And now in the age of the premium IOL and the expectations being through the roof and out-of-pocket costs and yada, 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 and they're realizing that there is a visual significance to the ocular surface. It's critical to outcomes in tfosdewsii. Certainly there wouldn't be an Ascaris algorithm project that I worked on without tfosdewsii as a foundation. So yeah, I think whether people know their day-to-day practices are being influenced by tfosdewsii or not is most likely they don't realize it. But most ophthalmologists who are now paying more attention to the ocular surface have been directly influenced by the great work that you all did on tfosdewsii.
Well, I think those images are, if you haven't seen the report, you've seen the diagrams, right? You've seen these descriptors, which I think they're just brilliantly done images. They're used in lectures every single day. Every single dry eye lecture features tfosdewsii classification system, management therapy, and I think that's brilliant. I've
I always tell people if they're not going to read it, at least look at all the pictures.
There you go. The pictures.
Which is why it's important to draw the pictures well, as I mentioned before. Now we have the overlap, including as much information in those diagrams as possible has been really important.
Were there any subcommittees that that didn't get included that you would have liked to have seen included, or any new subcommittees that you would add now in the next version based on what you know now?
The next TFOS report that Jenny's chairing is probably the biggest area.
Yeah, lifestyle. I think understanding the impact of lifestyle on the ocular surface and the risk that has in inducing dry eye from the things that we choose to do. So I mean that it actually covers some of the other subcommittees that were already part of tfosdewsii, like iatrogenic. So for elective surgery that patients have, that's it kind of comes into that. But it also looks at all the other things that we do in everyday life, the ambient environment we expose ourselves to, whether that's air conditioning and things like that, whether it's sitting in front of a computer for many hours a day. And I know COVID has not helped with that. We're all spending very much of our time in Zoom meetings, in front of a computer. So understanding the impact that screen use has on the ocular surface is really important. So yeah, I think if there was one other subcommittee, it would have been lifestyle, but I'm pleased to say that's going to become a whole workshop in itself, and we'll be able to explore, using the literature that has emerged. And there's as you say, a huge literature now that's come out even since tfosdewsii was published that we can incorporate into that workshop so that we can help better educate patients. I mean, if we know what we're doing to our eyes ourselves, we have the potential to modify some of those risk factors and hopefully reduce our chance of suffering from the symptoms of dry eye, perhaps the development of dry eye, perhaps be able to slow dry eye. There's a lot of information we don't know yet But yeah, pulling together the evidence that's available just now will be fantastic.
I think the second area that's been hinted on is the whole idea of neuropathic pain, the symptoms without any clinical findings. I think that's been alluded to, but I think that's going to be a big area in the coming, both in the last 2 years and then in the upcoming years. I think that's going to be a big focus, that it'll focus on dry eye as a portion of it being a pain syndrome rather than what classically has been thought of as a lack of tears or meibomian gland disease.
Yeah, and the report, the pain and sensation report, was fantastic at identifying that as an issue. But I think there's massive scope for us as clinical researchers to see improvements in the way that we can diagnose that. We're still not in a great position in trying to differentiate that from other types of dry eye. We now know it exists, so at least we're looking for it, but trying to pick a specifically a patient with neuropathic pain can be tricky. And then managing that, how that should best be managed, what proportion of it is true dry eye that we can do something about, and how much of it is a pain syndrome that requires referral to another specialty.
Well, as a housekeeping point, Scott, we've, in this just sort of natural dialogue that we've had here in the last 45 minutes or so, I've been keeping track, we've touched on every single subcommittee that had a report in the DEWS report. However, I will mention as a point of reference that there was one subcommittee that we have not mentioned. Does anyone, I know they know, do you know what that subcommittee was?
Your phone? No.
Gender and hormones, did we talk about that?
Yeah, we talked about that. The one subcommittee that I'm referring to was actually one that I was on, but there wasn't a formal written report in the TFOS 2, but it was mentioned in the summary, but it wasn't a formal report. It was the public awareness and education subcommittee.
Yeah, that was identified as important because it's all very well reading all the high-flying research that's going on and consolidating that, synthesizing that and consolidating it. But if you don't get that information out to the professions and to the public, then you're not doing a good job. And so that's part of what we take on board, especially those of us who are clinical scientists, is translating the outcomes so that they actually can be adopted in clinical practice. And so then this is important not just to get to the clinicians, but to get to the patients with, I think especially in something like dry eye disease, where we expect patients to undertake a lot of the management by themselves, and they can. In that case, we need really good engagement from the patients, and many of those want to be well informed about their condition, and they will sit and read it. So yeah, that was the purpose for that, and a lay summary was published for the public on the basis of all the different reports, which is available again. All of the reports are available in multiple languages on the TFOS website. So.
If we go back to when I first started in the 80s, I probably learned more from my patients than I did from anywhere else because there was nothing else to learn from. And patients, in all reality, they're the ones that we're trying to help both improve their symptoms as well as the surface of their eye. Engaging them is important. Once you start having to use eye drops yourself, you don't realize how difficult it is to use and how do you know it's getting where it's going. And you really need to have patients take a fastidious role. The good news is most patients with significant dry eye are very fastidious and really are engageable and will most of the time follow what you say if they trust you.
And
not as many diagnostics or therapeutics by a long shot back in the 80s. I'm guessing it was what brand of artificial tear, if there was more than a couple of brands of artificial tears at that point.
Heat and tears.
Yeah.
Mm-hmm.
Yeah, so it's been it's all gone along together, which is great. The better understanding of how dry eye occurs and the engagement of industry, who have put loads of effort into coming up with new treatments and helping progress these treatments based on the evidence we have. have, so that there are more options available for patients. And that then allows more people, more clinicians then get on board because they feel they have something to offer their patients. So that helps validate it more for the patients. They're willing to acknowledge that patients really probably do have a problem because they have something they might be able to offer. So I think we're in a much better position now than we were in the 80s. I hadn't quite started in the 80s. Early 90s, I started my PhD.
Well, and the other thing too is with the internet and so much information available, you really do need to have some source that you can say, hey, this is true stuff. This is stuff you can trust. This is backed up by literature and good research. Because patients come in, as you know, with all different kinds of things they've picked up on the internet. And the clinician needs to have the ability to say, well, yeah, that might work, or no, that's not really, really good.
Yeah, so giving the patient a voice is critical. I mean, so that they can turn up at their clinician and say, look, I'm having this problem. I want you to do something about it, rather than waiting necessarily for the clinician to go looking for it. I think that's quite important too.
No doubt, being proactive rather than reactive. And as Caroline Blackie taught me years ago, it's easier to optimize than rehabilitate. And the longer you wait, the harder it is to fix, as with most disease states, right? So now that we know it's a disease, which was a relatively recent recognition, we should be out looking for it. And I think I find this an invaluable tool. This is something I put into place in my own practice, and really has turned me into a local dry eye specialist. And, to me, it's just practicing eye care, optometry, ophthalmology to look for it. People come to us for a physical and an eye physical, and dry eye has such a big impact. We ought to be spending time looking for it. And this framework that you put together has been invaluable for making that something that can be an evidence-based approach that need not be overly wieldy. It can be done quite simply. Congrats to you.
I think that's critical, Scott, is realizing, yes, there's this massive report behind all of this, 400 pages, but all it really comes down to is clinicians just making a few tweaks to the practice that they're doing in order to be able to identify those patients. And I think the rewards that you get from addressing the issues that the patients have, hopefully will make it self-sustainable and make it worth doing in practice. But it really doesn't. I think it's important to realize it doesn't require a lot of change. It doesn't have to require a lot of instrumentation. There's not a lot of infrastructure required to make a difference for your patients.
Look for some symptoms and look for some signs, and away you go, quite simply.
So look for some symptoms, but try to use the validated questionnaires so that you can match that up with the TFOS-DEWS2 criteria, so that you're able to say definitively, yes, you do have a dry eye. I can validate what you're saying to me, what you're reporting with your fairly amorphous symptoms. That's coming up as being significant. So yes, we can now see from your symptoms, and I see there's some signs of, say, for example, some instability, which is very easy to pick up, tear film instability and clinical examination. Just with symptoms, a certain amount of symptoms and instability, you can tell somebody they have a dry eye. What you can't tell them is why they have the dry eye. But you can say to them, right, in my initial examination, I can absolutely tell you have dry eye disease according to the criteria, the consensus criteria. We need to get you back. We're going to do some more tests because I now know that you have dry eye. We need to find out why, and we need to do something about that. And that gives you then the option to expand your practice, to be looking at whatever's gone wrong and making sure that you're offering the treatments specific to the patient. Each patient is an individual. I think that has to be remembered. There's not going to be one easy fix that's going to work for all your dry eye patients. It's recognizing that there are different reasons why people have dry eye. So trying your best to, as we go back to that, restoring homeostasis, restoring the homeostasis of the tear film through whatever means you need to, based on what's gone wrong, which will, make a patient happy. And you, ultimately, as the clinician, happy if your patient's happy.
Very good. I want to thank you both again for joining us today on this episode of the Executive Summary. And Jennifer will actually be talking to you again on our next episode, talking about definition and classification. But it's been a real pleasure with having you share insights with us. Anything else, Chris, from you?
No, that was great. Thank you so much.
Awesome. Thank you guys so much for joining us today.
Thank you very much for having us.
Thanks for listening. Join us for our next episode soon. Find us online at www.ocularsurfaceacademy.com, all major podcast platforms, and YouTube.